That's fine. It wasn't late. It's there.
Someone's on Zoom.
Hello, everybody. We're going to give it just a minute and we'll get started. Can Michelle, if we can make sure everybody's on mute.
And my camera's off.
Barry and so on. Yep.
No, she
Okay.
just said Barry's on.
We hear you, Barry. Barry, can you
I
mute?
joined, so she knew that I would.
Say goodbye.
Okay, let's go ahead and mute all and then. All right. We are set to go. Hello, everybody. So we're excited to have you guys with us this evening. I'm really excited about tonight's opportunity because I've seen a lot of you talking about what is that website with Living HypoPARA? And gosh, they have some really great stuff on there. So tonight we are super fortunate to have Dr. Cristofides with us this evening. She's a physician and the Chief Executive Officer at Endocrinology Associates. It's an adult-only specialty practice in Columbus, Ohio. She is also the founder and director of Endocrinology Research Associates, an independent research facility. Dr. Cristofides earned her undergraduate degree at Ohio State University and her degree from the Ohio State University College of Medicine. She next undertook residency at Mount Carmel Medical Center in Columbus, followed by an endocrinology and metabolism fellowship at Louisiana State University Medical Center. Dr. Cristofides is dual board certified in internal medicine, endocrinology, diabetes, and metabolism. Dr. Cristofides is a fellow of the American College of Endocrinology. She serves on the Diabetes Algorithm Task Force at AACE and is the past chair of the Obesity and Nutrition Resource Center. Dr. Cristofides is on the board of Endocrine Web, including monthly advice column and podcast. She is also a reviewer, editor for several publications in the area of endocrinology, metabolism, and reproductive health. Dr. Cristofides is known for her patient advocacy, including a patient-focused book on living with hypoparathyroidism, her patient education video series on nutrition, Shop with the Doc, has won her a silver medal, the highest honor for a non-commercial entity in the prestigious Telly Awards. So with all that, we are so excited to have you this evening and to share with our HypoPARA community everything you know about hypoparathyroidism. So welcome and really thank you for your time tonight. I'll turn it over to you.
Thank you, Patty. I appreciate that very kind introduction, and I appreciate everyone's attention this evening. I know that we all have an incredibly busy lifestyle. We have incredibly busy family life, and I want to make sure that I'm respectful of that time and trying to stay on time here. So if someone could just make sure and let me know that you see the slide on the share screen, just make sure that we're on task.
We are.
Awesome. Thank you. All right. Oh, sorry. Go ahead, Patty. All right, perfect. All right, so welcome everyone. This is a presentation that is sponsored by Ascendis Pharma, and I am being paid to present this information, of course, on behalf of Ascendis. So this is, though, a disease state conversation. This is a conversation about hypoparathyroidism, not about any particular medications. So let's make sure that we keep this educational. Let's make sure that we keep our questions and our requests for information on the disease itself or on the questions about the disease. Supplements are fair game, but let's stay away from conversations about medications this evening since this is meant to be educational about the disease state specifically. So just going to kind of set some ground rules there. So hopefully over the course of the presentation, we will all be more understanding of what parathyroid hormone is, what it does, what changes when we don't have enough parathyroid hormone, what are some of the signs and symptoms that might be associated with that to give us some clues about what's going on. And we will talk about conventional treatment or conventional strategies for hypopara, which rest in the realm of supplements, and then how to help you advocate for yourself and advocate for the relationship that you have with your providers in terms of how to manage your hypopara. So let's talk about what hypoparathyroidism is. Now, it is most commonly a disorder associated with a surgical outcome that was not desirable or maybe even intentional, depending on what was happening for the surgery. The parathyroid glands sit behind the thyroid gland, and so they're named that way just based on their location. And they're named because they produce parathyroid hormone, again, based on the location, not because they have anything to do with the thyroid. So let's make that clear, that these are two very distinct sets of organs. They do not have anything to do with each other. They just have similar names because of their location. So when the parathyroid glands are damaged or removed, or perhaps you are born without them, this does happen, then we call it hypoparathyroidism. It is considered a rare endocrine disorder because fewer than a few 100,000 people have this disorder over the course in the United States. So as I've said, the most common cause is related to a surgical event. So the most common situation is when people have had their thyroids removed due to thyroid cancer or thyroid nodular surgery. And oftentimes the parathyroid glands, because they're so, they live on the back of the thyroid gland and they're so stuck to the thyroid gland that sometimes in the course of removing the thyroid gland, the surgeon is unable to save the parathyroids, or their blood supply is damaged, and therefore they don't recover after the surgery. That's the most common reason. The other next most common reason for surgical events removing the parathyroid or damaging the parathyroid have to do with head and neck cancers. So let's say somebody has had some sort of cancer or malignancy, and they're having a surgery in the neck area. That can also sometimes cause the parathyroid glands to become damaged and lose functionality after surgery. Follow up with that would be radiation to the neck for the same reasons. And then, as we mentioned, genetic or other autoimmune disorders that cause the parathyroids to be dysfunctional. Usually people are born with that particular component. They may be diagnosed in childhood. Rarely in a young adult life, say in your teens or your 20s, might that be diagnosed as a genetic or autoimmune condition. That's far more uncommon to be that old to get that diagnosis, but it does happen. It is rare, but it does happen. So as I was mentioning, the location of the parathyroid glands rest and reside within the back end of the thyroid. The thyroid sits just below your vocal cords in your neck, and I'm going to point, since those of you who might be looking at the screen, it's literally right here in the middle of your neck on either side of your vocal cords, and the thyroid itself is butterfly shaped and butterfly size. It's about the size of a monarch butterfly. So it looks like a monarch butterfly. It is the shape of a monarch butterfly, and it is the size of a monarch butterfly. The parathyroid glands themselves are about the size of a grain of rice or a tic tac. And as I said, they're embedded on the backside of the neck there. So from the front of the neck, you will not see them. You cannot see them. From the front of the neck, it's just the thyroid. And so when a surgeon is going in there to do some sort of surgery, you obviously have to flip the thyroid around. You have to try to get to the back of the thyroid to address the parathyroids. And that's not easy to do since you've got a lot of other really important structures in the neck. It's a very difficult surgery sometimes. And you can imagine if you've got a really large thyroid, or it's a very large goiter, or you have a lot of nodules, or there's cancer in there, it can sometimes be very difficult to protect those parathyroid glands, unfortunately, while simultaneously avoiding the vocal cords and the carotid artery, which you kind of need, and the jugular vein. These are all structures that anyone who watches horror movies know about, because they're the ones that make the most dramatic visuals on a horror movie or a slasher film, because they're the most important blood vessels of the neck. So we want to avoid them, of course, for those reasons. And so therefore, sometimes the parathyroids get a little bit dinged up in the process. The parathyroid hormone itself then is named that because of the location, but its job is to maintain normal calcium levels in the blood. That is its job. And your bones exist in part to keep you upright and give you structure so you can walk around and resist gravity to walk on this planet. But they also serve as a key repository, bank savings account, so to speak, or Fort Knox of calcium. They are the Fort Knox of calcium, and parathyroid hormone is the only hormone that has the ability to unlock that calcium. And it does so in order to maintain function in the body, which is critical for muscle function, nerve function, brain function, etc. It does so by maintaining calcium levels through regulation of the gut and the kidneys. Both the gut and the kidneys hold the key to holding on to calcium that you take in from your food, not allowing it to be excreted either when you go to the bathroom and you urinate or you defecate. The point is you get calcium from your food and your body needs to hold on to it. And it does so through the means by which you digest your food. And you are supposed to be able to store the calcium that you get from your food in your bones for use later at another time, because calcium is constantly turning over in the normal situation. So when somebody has normal parathyroid gland function, the calcium is constantly getting deposits and withdrawals of calcium, like gold from Fort Knox, in order to maintain calcium levels in the blood, because every muscle of your body, every nerve fiber of your body, which is basically everything that you want to do to eat, breathe, live, talk, see, and interact with the environment around you, you need calcium for these things. And that is why it is such a critical hormone and so important that we have a plentiful supply and readily accessible for our bodies. In the setting of low or absent or dysfunctional parathyroids, the calcium levels in your blood drop. And then you come to a standstill. And everyone who is on this call has, I'm sure, either seen this or perhaps sensed it or perhaps been, unfortunately, a victim of this, where your body just kind of comes to a stop. It comes to a halt because you cannot release enough calcium from the bones to accomplish the task that you needed to accomplish. And without parathyroid hormone to help you absorb calcium from your intestines and help keep you from leaking calcium from your urine, you're really kind of at a standstill. You're sort of in quicksand at that point. So the most important symptoms that are life-threatening are muscle and nerve related. The way to think about it is that you need calcium to allow the muscles to sort of cock into place and then fire to act. That literally is the mechanism of every muscle in your body. So calcium is critical to every single muscle fiber to allow it to relax and then contract and then relax again. So you can imagine for muscles that are important, like say for breathing, you have to be able to do this 18 to 20 times a minute, and then maybe even like 30 times a minute if you're, say, exercising, but let alone your digestion, your heart, etc. These are also critically important functions in your body that are actually driven by muscles that are beyond your control. They happen automatically without you thinking about them. But if those of you who've been on this call who have some form of hypocalcemia or HypoPARA know that you sometimes, when you are in trouble with the low calcium, you start to get cramps. You start to seize up, and the muscles that are voluntarily in your control no longer work. So that can be quite scary, and it can be life-threatening. This is serious, and so we do worry about muscle cramps. We do worry about muscle spasms. We do worry about a situation where you get into trouble, where if you start to have the hand cramps and the foot cramps, and you start to seize up and curl up like this. We do worry about the rest of your muscles that are not in your control, that we cannot see, we cannot measure, we cannot touch as benchmark of how safe you are, where your calcium levels are. The next most important symptom is unfortunately the neurologic symptoms. So many people do not know, or many people are not aware of how nerves function. They work like in a bath of electrolytes. They are bathed in sodium, potassium, magnesium, and calcium. So think of them as like one of those little electrolyte baths or like a sea salt bath. And the electrical conduction, the electricity that moves down your nerves from the beginning to the end, passes through sort of a field of electrolytes, sodium, potassium, calcium, magnesium, etc. These are required in a certain relationship and a certain volume for every nerve to work. Well, if you're missing one, like calcium, then the nerves don't work so conveniently. They don't work so easily. They don't work as nicely as you'd like them to. And so what's the biggest bundle of nerves in your body? But your brain. So the most important symptom for you and your family to understand is your brain doesn't quite work right. You have significant mood changes, and I mean significant. And it's going to be difficult to hear this, but for many of you who are suffering from hypopara or hypocalcemia, you're going to have an advocate in your family that's going to be a part of your conversation or a part of your care to help sort of translate what's happening in terms of when you're behaving normally or when you're not behaving normally, because you will not be aware of how not normal you're behaving because it's just you, but your brain is clearly not working correctly. And so I want to just impress upon people in the audience, if you are the loved one of someone with hypopara, please have patience and empathy. Your loved one is not going to behave normally sometimes when their calcium is low. And that may be your only sign, and that may be your first sign that trouble is about to happen before they start to get the cramps. So that can also manifest in terms of like anxiety or depression or memory problems, words that people typically use to describe this as brain fog, difficulty focusing. Of course, there's headaches, and any number one of these complaints that are on this list at any one time or all the time because of how important calcium is to overall bodily function. Now, in the course of getting hypoparathyroidism and trying to treat it with conventional therapy, which is the supplements that we will talk about later, unfortunately, because you're trying to sort of, put your finger in a dam that's already breaking, bad things are going to potentially happen to the muscle tissue and the nerve fibers that are really dependent on calcium for their function. These are things like kidney stones or seizures. These are very, very specific complications of having low calcium or having inability to move calcium correctly in the body. The most important muscle of your body is your heart, of course. And so your heart can become damaged from the low calcium in the long term and not function correctly. And then you can end up with irregular heartbeats because that's the neurologic portion of your heart. So think of your heart as the pumper and the which is what we consider the plumber. And then there's also the electrical component of your heart, which is your heartbeat or your heart rhythm, and that's the electrician of your heart. So if we already said that the muscles can be damaged from low calcium, that would be the plumber becoming damaged. That's ischemic heart disease. But if your electrician of your heart is also damaged or becomes damaged because of low calcium, that can lead to irregular heartbeats or irregular heart rhythm. So that's how the heart can be affected in two different ways because of the low calcium. The kidneys become damaged due to kidney stones and their inability to continue to hold on to calcium long term because we don't have parathyroid hormone around. And then a weird one, a lot of people may not expect, is the cataracts or a higher risk of infection or risk of inability to fight infections because calcium is important for immune system communication, as is vitamin D, actually. It's really more the vitamin D, not the calcium. So how do we diagnose hypoparathyroidism? Well, there really isn't anything else that causes low calcium, especially in the setting of an obvious event like surgery. If somebody has low calcium and it is genetic or autoimmune, it may be a little bit difficult to identify. It may be harder to find because it isn't something that's expected. It's so uncommon, it's not a routine test, nor should it be a routine test because it's just so uncommon. It's not something that is going to happen out of the blue. But situations that make it more likely are in individuals who have a family history of other autoimmune diseases in the endocrine space. What do I mean by that? Well, those would be diagnoses of autoimmune thyroid disease like Hashimoto's or Graves', or other autoimmune endocrine diseases like type 1 diabetes, other autoimmune diseases like in the GI space like Crohn's or colitis. Rheumatology diseases that are autoimmune are things like lupus, rheumatoid arthritis, psoriasis. These are autoimmune diseases in other spheres of medicine that can overlap with each other. That we say that they play in the same sandbox together. So if you have a personal or family history of these other autoimmune diseases, then autoimmune hypoparathyroidism may be at play. And unfortunately, for someone in that position, if they have thyroid surgery, they may be more at risk for developing hypopara after the surgery, unfortunately. So in the setting of surgery, obviously we know that the surgery happened, and obviously you had blood work done before the surgery that you were fine in the calcium arena because that's part of your pre-op testing. And now you find yourself after surgery with abnormal calcium levels. So it's pretty straightforward. You do a parathyroid hormone test. you do a phosphate level, and if you have two readings that are inappropriate. And when I say inappropriate, I mean that the calcium level is at the very low end of normal or below normal, and the parathyroid hormone level is not at the high level of normal, indicating it's trying to compensate for that low calcium. In the endocrine space, we sort of envision the hormones and the product or the thing that they control on either side of a teeter-totter. It's the best way to envision this. So if you think of calcium on one side of that teeter-totter or seesaw, and then the control factor for calcium is the parathyroid hormone. So if calcium is low and that part of the seesaw is on the ground, then the parathyroid hormone needs to be high in order to compensate, to indicate that it is sensing that the other side of the teeter-totter is down on the ground, the calcium is low, and the parathyroid hormone, the parathyroid glands should sense that they need more parathyroid hormone in order to compensate and make the calcium levels normal. So it should be high in order to address that low calcium. So that's why when the calcium is low, the parathyroid should be high or high normal. And if it's not, then you know that the teeter-totter has broken, the seesaw is broken, and we need to call it hypoparathyroidism. We do other tests, blood tests, as well as imaging in order to get a baseline understanding of kind of where things are. Those are tests like the magnesium and the vitamin D, 24-hour urine for calcium and creatinine, and then of course x-rays to look at where the kidneys are right now to see if there are any kidney stones already, or to get a baseline to understand if more form, where they are or how many might be there. And then also usually bone density, depending on your age, or if you are a female, say of menopausal age, in order to understand where your bones are starting from, because you can lose a lot of bone density in this process as well. So moving on to the management of hypoparathyroidism, we call this conventional therapy because it's really our only therapy right now. So that's why I was asking for everyone to sort of respect the fact that we're talking about what is currently considered standard of care, meaning this is the rule, these are the rules, everyone knows the rules, everyone has to follow these rules at minimum right now. So this is the minimum expected standard to manage hypoparathyroidism. It is a foundation of calcium and vitamin D. There are multiple forms of calcium that you can consume in a supplement form, and there are multiple forms of vitamin D that you should consume in multiple forms, and we do this in balancing the other labs that we track to make sure that they stay in line. On the oral calcium supplements, you can either do straight up calcium carbonate or calcium citrate. Let's talk about the differences for a brief moment. Calcium carbonate is pretty traditional. That's your Oscals, that's your calcium supplements you typically get that are listed as 500 milligrams or say 750 milligrams. They're huge honking horse pills. They're often quite large and difficult to swallow. They're very chalky. Now, the reason that we sometimes recommend calcium citrate is because calcium citrate's a little bit better absorbed. So for the same milligram strength, 500 milligrams of calcium carbonate or 500 milligrams of calcium citrate, you get more calcium absorbed from the 500 milligrams of calcium citrate than you do from calcium carbonate. So effectively, you get more bang for your buck. And unfortunately, calcium citrate tends to be a little bit more expensive than calcium carbonate, so it ends up being, you sort of end up paying for it one way or the other. You either have to take more calcium carbonate pills in order to get enough calcium, or you can afford to take less calcium citrate pills. It's more expensive. You get more out of it, though. Now, a couple of things to note. Calcium and the calcium citrates and the calcium carbonates sometimes come in chewable forms. Be careful that there isn't other things in them that might impede the absorption of calcium, other binders like other fillers, etc. On the converse side, consuming vitamin C with the calcium supplement at the same time, and a minimum of 250 milligrams of vitamin C is necessary, will enhance the absorption of the calcium being released from the supplement that you take in, because calcium doesn't like to be released. Calcium likes to be held onto on that supplement, and it's not, your body doesn't do a really good job of getting calcium out of the pill that you consume. So consuming it with vitamin C at the same time will enhance its absorption. Now, I'm going to jump down to the bottom of this slide for a minute to point out that we do also want to use magnesium supplements in this setting because your bones actually use magnesium too. They don't just use calcium. So in order to prevent people from getting tired of the burden of the number of pills you have to take in this setting, I often personally recommend Rolaids chewables specifically. I do not have any financial association with the company that makes Rolaids. I wish I did, otherwise, because I could tell them to make more of them because they always seem to be in short supply. But Rolaids specifically, the antacid tablet, is a combination of calcium and magnesium in the same tablet. So you are consuming two of the supplements that we need you to get with one chewable tablet. And so if you add to that a vitamin C chewable at the same time, you end up getting your vitamin C, your calcium, and your magnesium all in one go, and with an enhanced absorption of both of the calcium and the magnesium at the same time. So you cannot get that with other chewable antacids. So Tums doesn't have it. Pepsid AC doesn't have it. None of those other ones do it. It's strictly Rolaids and branded Rolaids. So I apologize ahead of time for being so specific, especially when Rolaids tends to be in short supply sometimes. But if you can find it, that's a great source of both of those supplements. If not, by all means, go to a health food store and look for it yourself. There is no reason it has to be specifically Rolaids. I'm just trying to give you a cheap way of getting it, because I know that Rolaids is pretty cheap on Amazon most days. And so you can just kind of go from there. If you can't find it, go to a health food store with that particular idea in mind. Now, the vitamin D, there are two forms of vitamin D that you need to be aware of. Everybody on this planet who doesn't live in the tropical jungles, and especially in the US, needs the inactive form of vitamin D at all times, always and forevermore, because we don't get enough sun, and it's only sun that gets it. You cannot get it from your food. I'm sorry. Anyone that told you that is wrong. You cannot get vitamin D from your food. Vitamin D is very, very unstable. And so anytime you see it says added vitamin D, whether it's in your dairy product, in your milk, or in some food, just be aware that it's very unstable product and it's going to degrade immediately. And so it's not really a bioavailable, it's not really an absorbable form of inactive D. That my entire undergraduate research was in this. So I assure you that anything that you see that says vitamin D in food will not be absorbable. Now, the problem is in the setting of hypoparathyroidism, you need the parathyroid hormone to convert the inactive D to the active form of D, which is what is responsible for absorbing calcium from your gut and from your kidneys. So you can take all the inactive D you want, all the supplemental D you want that's over the counter. It isn't going to matter in the setting of hypoparathyroidism because you cannot convert it appropriately. So that is why we specify and use active vitamin D in this setting in order to to create the drive to absorb calcium from your kidneys and from your bowels, because parathyroid hormone converts inactive D to active D, and that is what drives calcium absorption, specifically from the bowels and the kidney. And you have to have this as a prescription, and it has to be monitored because you can get toxic on this particular form of vitamin D. A really good cheating way of knowing whether you're taking active D or inactive D is by the color of the tablet. Inactive D is always a white capsule, and active D is always a blue-green gelatin capsule or jelly cap. So you should usually take both, but in the active one or the green one for calcitriol, you have to make sure that if you're getting the actual gelatin capsule, you got to make sure that that's being monitored by a prescription. Calcitriol also comes in a white tablet, not a capsule, that we can split sometimes if we have people that need to take a lower dose. So calcitriol comes in, so the active D comes in either a tablet or a blue-green caplet. So just pay attention to the fact that vitamin D has two different forms. The inactive is usually over the counter, and the active form is unfortunately only ever available by prescription. So that has to be monitored by your provider. Sometimes when you're trying to do your best and take all the supplements that you need and trying to eat a healthy diet, unfortunately, sometimes you can get buildup of the sodium and buildup of phosphate, which are unfortunately components of the food that we eat, even healthy foods that we eat. And because you lack the ability to move sodium, potassium, magnesium, and calcium around, these things can build up. And so we oftentimes have to give either water pills or other medicines called phosphate binders to keep protect your kidneys and protect your bowels from the consequences of these other supplements. So here are some food sources for dairy for calcium in particular. I already mentioned that you can just kind of ignore the vitamin D ones. Sorry. Time in the sun. Time in the sun. Time in the sun is the only way you're going to get inactive vitamin D, but you can't get active vitamin D that way. So you still need active vitamin D. And the phosphorus-rich foods are the ones you might want to try to avoid in order to limit the amount of exposure of excess phosphorus that you get in the setting of trying to balance your calcium. The most important one, the most significant one is going to be carbonated beverages, carbonated soft drinks, carbonated beverages. The carbonation process, so anything that makes the liquid sparkly is going to have phosphorus in it. I'm sorry for those of you who like your beverages carbonated, for those of you who like your colas or like the fizzy drinks. I apologize ahead of time if you are now crushed by the fact that you probably should avoid them. That is the single highest source of phosphorus in anybody's diet. Above and beyond, literally, you could add up all those other ones on that list and you wouldn't get as much phosphorus as you get from soft drinks. And it doesn't even have to be a lot of soft drink. An 8-ounce can of soft drink or an 8-ounce can of soda, even a 16-ounce can of soda, has more phosphorus in it than all those foods combined. So the single greatest way to reduce your phosphorus is stop drinking fizzy drinks. I apologize ahead of time for that one. So how do we monitor this? Well, in the beginning, when someone's newly affected by HypoPARA, we actually do blood work pretty often, maybe every week, maybe even a couple of times a week while we're trying to adjust the doses of the supplements to make sure that you're safe. Because obviously your calcium needs might fluctuate on a day-to-day basis. And if you're new to HypoPARA, we have no idea what your needs are going to be. So it would not be unreasonable and it's not unusual for us to check blood work a couple times a week, once a week, and then slowly go to every other week or once a month after we've balanced your needs. And then under normal ongoing maintenance, we might check the same labs, once a quarter, twice a year. And obviously the urine for the calcium, et cetera, other tests that we're going to do might be less frequent because there are things that are impacted less commonly. But certainly in the beginning, it's not unusual to need blood work very regularly. So I do strongly recommend making sure you have access to your patient portals for your health system so you can look at your labs. You can look at them, on your own, have a family member help you download them into spreadsheets to keep track of them. And I do strongly advise diaries or pre-made diaries, pre-made trackers. There is one in my book that you can get on, it's available on Amazon Kindle. You can get those and fill them in yourself and have your family fill them in. And I think these are important for your healthcare professionals to hear also from your family, when they think you're particularly struggling or when they think that you're having bad days, because that may be a time that you want to go get your labs done ahead of schedule. In my office, we have what's known as a standing order. My patients have standing orders, meaning they have a lab order on the computer system in the lab facility that they prefer to go to that is there and available to them anytime they feel bad. They can go to the lab anytime they feel bad to check on their levels without requiring an appointment with me, without requiring a phone call to my office, without requiring justification by anybody to go get their blood work drawn. Because if you have a change of event, if you have a change in your lifestyle, if you have a change in how you feel, and it happens at Saturday night at 10 o'clock at night, do you know what I don't want you to do is wait until Monday to call me in case that health event is actually critical. I don't want you ending up in the ER on Sunday because you felt you had to wait to call me on Monday morning to tell me you needed care. And that's how every office should be run. That is how every healthcare professional should treat HypoPARA. And you need to be in control of that. And that is what we recommend in order for you to be able to manage that, or for your family to say to you, you know what, you don't look so good. You're not behaving so well. How about we go get your blood work drawn? And so then you can follow up with your doctor on that. and see if you need to make an adjustment or get the data from your portal. And we do expect healthcare professionals to share with the patients or the family members, what to do in the event of poor, how you're feeling poorly or if your levels are high or low, et cetera. So pre-made trackers are good for putting that information in. And then I recommend you take these with you to your healthcare appointments so you can discuss this with your healthcare provider. Because let's say you didn't feel bad enough to go to the lab, but you had ups and downs, or you see patterns associated with when you work out, or if you have a stressful event, or maybe when you fly, or maybe when you drive a long distance. It doesn't matter what the life event is. Everyone has a pattern to their life events, and everyone has a pattern to when they feel poorly, or perhaps just more poorly than average. And if you can track it and document it, then your healthcare provider can look at that and then give you a plan, share with you a plan of attack on how to address it the next time that is going to occur. So you don't have to suffer through the next round. Like, hey, every time I go for a long drive with my family, or every time we go out on the lake, every time we go on our boat, every time we go and do whatever, I feel more poorly than normal. I feel more tired than normal, and this seems to happen every single time. And so then your healthcare provider can give you tips and tricks on what to do to address that concern the next time you do it, especially if it's something that's a routine event. Everyone knows we want you to exercise. Everyone knows exercise is good for you, but exercise can be really challenging for people with HypoPARA because the thing that you cannot do is waste calcium or get more calcium. And when you contract your muscles, which is what you do when you exercise, and you move your muscles in a way that's not just sitting here talking to me or talking to your family members, you're chewing up more calcium. So your ability to exercise will be diminished severely. What we recommend is that you still try to look at your exercise routines with both cardiac fitness in mind as well as muscle fitness in mind in terms of like resistance training, weight training, but plan for it a little bit more formally, meaning plan for like a warm-up period to kind of see how you're doing, test the waters, see how your body's feeling that day, perhaps chew a bunch of calcium, perhaps chew a little extra calcium going into the exercise. And exercise, whether it be a cardiac workout on the treadmill, rower, whatever, or the weight training, and do it in discrete blocks, maybe 10-minute intervals, maybe even 5-minute intervals, just enough to do something and do it safely without putting you over the edge, without putting you into crisis, and then plan on building that up slowly over time. I would rather you do workouts 4 or 5 times a week for 15 minutes only to ensure that you can stably manage your calcium through the workout than try to go for a 3-hour bike ride. You're just kind of going to not really be able to do that very often because it's such a demand on your body. So, if you can, that's fantastic. And if you build up to that, absolutely fantastic. But you're not going to do it right away. You're going to have to build up a tolerance for it through diarying, through conversations with your loved ones or your friends that you're out with or your trainer, that you're going to have to build up sort of a plan of attack in order to safely get there and know what the limit is and what symptoms you might have that tell you you've pushed it too far so you can stop immediately. So the idea here is not that you can't ever, but hardly ever, and really never without proper training and fitness and getting there with a plan and a slow ramp up rather than an aggressive ramp up. And then, of course, on the cool down, be prepared to take extra calcium so that you can, recover nicely. So how should you communicate with your healthcare providers? Well, communication is key. I'm going to just remind everyone we're not psychic. I know that seems crazy to say, but I promise you we're not psychic. So I can't help you. Your healthcare provider can't help you if you don't tell us how you're feeling. We can't help you if we don't know that you're in trouble. We can't help you if you don't speak up. I know it may seem really frustrating, it may seem embarrassing, and it may be really weird and difficult things like sexual function, like intimacy, like your interactions with your boss, your interactions with your children. It's okay. We've seen it all. We've heard it all before. There isn't anything you're going to say or tell us that isn't appropriate. But I can't tell you a response. I can't give you a response. Your healthcare provider can't help you address those issues if you don't say your mind. And that's why we ask you to write them down. That's why we ask you to be attentive to this. That's why we ask you to have your loved ones either with you or also help you write them down. And these are the things we ask you to pay attention to. Make sure you have access to your medical records. Make sure you bring someone with you or have maybe a tape recorder if your doctor allows it. Make sure you take notes. Make sure you know how to manage sick days, how to manage those events when you don't feel so great, or how to manage planned activity. And make sure you utilize the staff in the office, the pharmacists that you interact with. We all have different perspectives on how to help you. We all have different education and training that is specific to our roles. We're not all equivalent. We're not interchangeable. So the pharmacist may have tips and tricks for you that I don't have. My nurse may have tips or tricks for you that she's heard from other patients that I don't have. There is not any one person who has every knowledge point that might help you. The one thing I am going to say, though, is I do think, and I'm going to be a little egotistical in this regard, you really have to have this managed by endocrinology. A lot of people get stuck with the surgeons who caused the problem in the first place, and they stay there out of guilt, or the surgeon keeps you out of guilt. I'm sorry, this is a extremely specialized metabolic problem that requires expertise and very specific expertise. This is not a family doctor. This is not a surgeon. This is not your oncologist. This is not your primary care provider. They're your PA, your NP, or the urgent care, or the minute clinic. I'm sorry. This is the one time you cannot be managed by anybody but endocrine. And even if that is a telehealth appointment with an endocrinologist that's maybe not in your area, even just to check in and give you answers to these questions in between the time you're managing with a local provider, that's still better than nothing, because we are going to be able to give you some very specific expertise and very specific guidance related to parathyroid hormone functionality and safety assessments that your surgeon and your primary care provider will not have. And so you can get labs done with other providers, absolutely. You can go in and cry on their shoulders, absolutely. We all have that ability to empathize and give you advice and help you navigate these waters. But the endocrine space is the only space that really is the expertise for parathyroid hormone. So patient advocacy groups absolutely are my favorites in this situation, because you're going to learn from your peers, you're going to learn from your fellow patients, because that's how we learn. That's how we learn. We learn from you when you say, you know what, these other 3 people I talked to did this, 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 and this, and it made them feel better and it helped. That's great. Fantastic. I'm more than happy to hear about what's been helping other people, because you're living with a disease, not me. You're the one who needs to know how to manage your disease safely and adequately to live your life. So if you learn of a trick that helps, I want to know about it. If you learn of a tip from somebody else and that makes everybody happier, perfect. I want to hear about it. Make sure that you always, though, tell everybody what supplements you're taking, what herbal remedies you're taking. I know it doesn't seem like it's going to be a lot, and I know it may not seem like it's important, but I promise you, you have no idea the extent with which people compound or add things into these supplements or into these pills or into these, even like protein smoothies, even protein shakes, that may be impacting you positively or negatively. So everyone needs to know about this if you're going to talk about medications and supplements. So these are more potential questions. We've addressed some of them already. For some people, I have some people who see registered dietitians to help them navigate their food choices because they have other illnesses that are hard for them to figure out how to get adequate calcium in. And so there are other specialists that you might need to see, and you might need to ask for that help if you're feeling overwhelmed. Not everybody is a nutrition specialist in terms of patients, nor providers. So this may be a specialist you might want to see. There might be a kidney specialist you have to see. There might be other signs or symptoms that you're not seeing in the tracker, or that your advocacy groups haven't mentioned, that maybe your provider wants you to be paying attention to, specific to your condition, because maybe you have a different form or have something unique with your HypoPARA that your provider wants you to keep track of, that's special for you and not necessarily applicable to everybody else. And unfortunately, long-term goals might just be to keep you from getting kidney stones or to keep your heart functioning well. It's almost never going to be getting you off medications or getting you off supplements. But that is a reasonable question to ask. It also is a reasonable question to ask, what caused your hypoparathyroidism? And if you had surgery, you know what caused it. And if you didn't have surgery, that is important to ask. It is important to chase that down, because that means it's probably running in your family, and you're going to have loved ones that might be impacted you're going to need to know about and be able to advocate and educate them as well. So in summary, HypoPARA is uncommon, but if it happens to you, it sucks. I know. And if it happens to your loved one, I'm sorry, you are going to be in for the long haul, and it's their advocate and ensuring that they stay safe and that they stay well involved with their providers and advocating for good care and stable care and educated care. And that's going to involve calcium and vitamin D and keeping those emergency supplies with you at all times, on hand all the time. I strongly, strongly advocate for the use of a medical alert bracelet, a medical alert necklace. You can have apps on your phone now. You can have medical alerts on your phone. I really strongly suggest that, because if you are in an accident, through no fault of your own even, and you are unable to communicate with emergency personnel, they're going to look on your phone, they're going to look on your wrist, they're going to look around your neck, they're going to look for some sort of medical alert information to know how to safely manage you in that situation. And make sure you avoid the phosphates. I'm sorry again on the sparkling waters and the sodas. And make sure you have a plan for today, a plan for immediately, a plan for long term. And make sure that you discuss this plan and how this disease is impacting your quality of life with your provider, to make sure that you have a good plan for how to navigate those waters to keep you safe and sane. There are, of course, loads of patient resources. We've spoken about them already tonight in terms of, what to know about HypoPARA. And there are, of course, advocacy groups and websites and share groups. And the National Organization for Rare Disorders is really helpful as well to help you connect to a support group or an advocacy organization in your area physically. Of course, there's the Hypoparathyroidism Association, which is by far and away the one that seems to be the most beneficial in connecting individuals. And they do events and connect you locally with other people so that you can meet others like you and share and commiserate. But living with HypoPARA is a huge impact for your local organizations as well, and hugely beneficial, connecting you with resources and trackers and diaries and information and questions and things that you may not have thought about. So I do hope that you found this breadth of conversation to be helpful and meaningful. And I hope that you've taken heart that there are a lot of things that you can do to improve your quality of life, improve your interactions with your providers, and help advocate for yourself and for your loved ones to make sure that you can feel like you are controlling this problem, controlling this disease, controlling this issue, so that it doesn't control your life and you don't live in fear of it. Because that is my biggest hope for you, is that you can ensure the control is in your hands and not in feeling like you're a victim to the labs every time you go get a blood draw. So with that, I'm going to go ahead and stop sharing to make sure that everyone has a chance to ask their questions in these last minutes.
I'm trying to unmute. Okay, got myself unmuted. Thank you. My goodness, that was I was really inspired, because what you're talking about is like, you're so real. You completely understand what the heck we're going through. And when you said big honking pill, I was like, oh, she got us. Because a lot of us have put that big old honking pill down there and went, oh my goodness. So thank you for really understanding our disease and really helping us with it. So we are going to open up the chat for a few questions. I will go ahead and kick it off. I was thinking in the beginning, you talked about bone turnover and deposit withdrawal. So I was wondering, there's two things to this question. Can we measure that, and how would we measure that? And the second thing is that's what causing some of us to have pain?
Yeah, so that's a great question, Patty. So if you think about the withdrawal and the deposit, we do have labs that we can measure. We do have labs that we can use to check that. But those labs aren't always helpful, because they're more helpful when they're high than when they're low. So those labs are not super good at distinguishing when there's low turnover. They're more appropriate when there's high turnover. That's how we usually use them. So, but yes, that is correct. That is correct. That is often the source of the pain, in relationship to the fact that your bones are kind of stagnant. It's sort of like they're getting full and you can't move. They're like, I can't take any more and I can't give you any more. So that is not uncommon.
Okay, very good. And then we have a question in the chat. When I menstruate, I start feeling tingling or tickling. Can I take extra calcium without communicating with my doctor? Also, can calcium supplements cause kidney stones?
Yeah, so obviously I have to be careful, like I'm not your
Mhm.
provider, but the general rule of thumb is always that if you start to feel the onset of hypocalcemic symptoms, then we do usually say to people, please take extra calcium. And menstruation is exactly the time kind of regular event I'm talking about that causes a strain on the system, that causes a change in your needs. So every woman on this call knows, like when you menstruate, you're not normal under normal circumstances. Like things are not happening normally. You have to be prepared for that. And so there's an example of something I would say for sure bring it up at your next appointment. For sure, put that on your list. But in general, yes, the rules are if you start to feel tingly, weak, the numbness around your mouth or feeling like you're I call it like feeling like a sensation of like spiders are like running
Your
across
bees are
your
buzzing.
lips. Yeah, bees are buzzing in your mouth.
Yep. Mhm.
Yeah, bees are buzzing in your mouth. I actually, some people have described it as bees in their nose, like they feel like there's like
Mhm.
bees, or like there's bubbles, like you've drank a carbonated beverage and like the bubbles got up into your nose. Um, Feeling like all of a sudden like your fingers are like on fire, right? Like carpal tunnel-y, like shooting pains.
Mhm.
Those are generally symptoms that we would say to somebody in as a normal rule, we would educate and say, please, by all means, take some extra calcium. Now, whether you take an extra calcitriol at the same time or not is a different story. That one you have to get from your local provider based on where your vitamin D levels normally run because it's such a potent drug and toxicity is possible. You do have to be careful with the active vitamin D. It's a little bit harder to just give you a blanket statement to say, yeah, take extra. Whereas calcium, it's a little bit easier. And
Right.
the kidney stones are caused because you have to take so much calcium and you don't have enough parathyroid hormone to move it out of the urine into the bone, then it does kind of get stuck in the kidneys and cause stones. So normal non-hypopara people don't get kidney stones from calcium supplements, but hypopara people, because they don't have the deposit slip or the withdrawal slip for the
Mhm.
bank to take it out of the urine and put it in the bones, from one bank account to the other bank account, then it gets stuck there, and then
Mhm.
that's how you get the kidney stones.
Okay. And so would you agree that calcitriol is not a fast acting, but the one like just a regular supplement is a fast acting?
Fast acting and not fast acting is kind of a difficult. It's a difficult thing to say. I would say
Mhm.
nothing is actually terribly fast acting,
Right.
but calcitriol is slower than calcium.
Okay.
Um, but that's kind of individual. So
Right.
typically calcium will work within 30 to 60 minutes, especially if you take it with vitamin C.
Mhm.
Calcitriol, we typically say takes 2 to 4 hours to really kick in. If you're taking antacids, then you're not helping the situation because you need acid. The point about taking vitamin C is you need acid for the calcium to dissociate from the tablet to separate out into calcium and non-calcium components of the supplement. And so you need the acid to do that. So if you're taking antacids, then it's going to take a lot longer for the calcium supplement to get absorbed, a lot longer for it to work. So taking vitamin C is helpful, but may not be
Mhm.
able to overcome the lack of acid in the stomach. And then you might need a higher dose of vitamin C. But then you have to worry about, again, the kidneys. Um,
Gotcha.
so it's sort of a misnomer to think about fast and slow acting. Everybody kind of has their own little tricks.
Right.
Um,
Okay. So
Other things,
basically, calcium supplementation, you really do need to speak with your doctor. But as you said in the beginning, if there's kind of a rescue situation, supplementation, not calcitriol, is probably more of your answer.
yeah, until you can get to your local provider and have that
Mm-hmm.
conversation with them. And the milligram strength is a minimum of 250 milligrams for the vitamin C and upwards of 500 if you don't have enough, like if you're taking an antacid or you're taking like say a Pepcid or a Nexium or
Mm-hmm.
Prilosec. If you take medicine for acid reflux or ulcers, you may need a higher dose of vitamin C specifically for those reasons. So I
Gotcha.
do want to mention that. And the dose of the calcium supplements kind of fixed. I'm sure you all know that, sort of like you get what you get. You get
Yeah.
what you're lucky to get what you get when you go to the store. And
Right.
more isn't always better because it doesn't always mean it's more available to be dissociated when you take that tablet. So I typically like the chewables for those reasons because it's going to break down in your stomach faster. So that's kind of
Mhm.
why we like that. I have seen some liquid calcium supplements and some CalMag supplements that are liquid. I do think that when you're talking about speed of recovery, that may be a better solution for some individuals to use the liquid form. But again, your mileage may vary depending on what your problem is.
Right.
In terms of are you dealing with the fact that you're stressed out and you're like hyperventilating, or are you dealing with the fact that you're driving and you're panicked because you're getting the
Right.
tingling sensation? You got to pull over and do something now.
Right. Right. Very good. Thank you. Amy had asked, are you suggesting that we take vitamin C every time? And how many milligram?
Yeah, so I typically do suggest that you take vitamin C every time you take calcium, or at least 3 times a day, to ensure that some of the calcium you're taking is getting that higher absorption quality, or higher absorptive quality. And so the minimum, as I said, is 250. But I do suggest that you take it every time you take the calcium, unless you're one of these people who has to take calcium 5, 6, 7, 8 times a day. And there are some who
Okay.
do. That's why I said at minimum 3 times a day, maybe even 4 times a day. But if you're doing calcium more often than that, then perhaps not more often than that. Certainly, if you're finding yourself taking rescue calcium very regularly, then you might want to reconsider how often you're taking the vitamin C.
Gotcha. Okay, very good. And then, so I have two questions. I know we only have like 3 minutes left, but one is, can we get away with telehealth visits to experts, or do we have to be in person? And if we have to be in person, how often?
So in person is going to vary depending on whether you're early in your disease or late in your disease, because obviously early in the disease, there's a lot of education that has to be conducted. There's a lot of examination. We need to see you. We need to check your Schwastex and your Trousseaus and look at your muscle tone. Of course, those can't be done by telehealth. Telehealth appointments with experts are absolutely fine, and those laws or rules vary by state and vary by the provider's comfort level as well. But by no means should you restrict your access just to in-person visits, because just like this meeting, we're having this educational session. Education is education. There is nothing that restricts education in terms of educational conversations, which is why I talked about the team. There is going to be a team. There isn't going to be just one person that you need to rely on to manage this situation. So whoever you can reach out to by telehealth to give you greater educational opportunities, by all means, I strongly recommend. And as I said, those laws or those rules vary by state and by provider's preference.
Great. Perfect. And then the last question is about heat and elevation. How does that affect, and how should we as patients think about that and react to that?
So any change in body status, like if you normally live at altitude and you go to sea, or you live at sea and you go to altitude, can potentially change your calcium requirements. And if you chronically live at altitude, especially because that changes your acid-base balance in your blood, that changes your pH of your blood. A lot of people think that your pH is perfectly neutral in your blood. It actually isn't. And calcium is extremely sensitive to the movement of the pH in your blood. So when you chronically live at altitude, or you exercise at altitude, or you go to altitude, that's going to change the way calcium interacts in your blood, not the amount of calcium. This is an important point. It's not the amount of calcium in your blood that changes. It's the availability of that calcium to be available. It's the availability of that calcium for your muscle and for your nerves because of your blood pH changes. So it will either, your pH in your blood will either allow the calcium to more freely interact with your muscles and your nerves, or it will hold on to it more tightly and not allow it to be available to your muscles and your nerves. But if you draw your blood levels are the same.
Mm-hmm.
So it has to do with, it's sort of like remember, calcium is bound in your blood. It's bound to proteins, and it circulates bound with protein. And when we measure it, we're measuring the bound form. We don't measure the free. And so we use the bound as a sort of metric, what we call a proxy, we assume the free based on the bound. And under normal circumstances, that's a really good assumption, really good assumption. But in times of heat, stress,
Right.
exercise, altitude, even in a plane, this is why I made the comment about travel. People will notice it when they're traveling. People will notice it in a plane. When you're in a plane, the plane is not pressurized to sea level. The plane is pressurized to 10 to 15,000 feet. And you're at 30,000 feet in the plane. And so you might be much, much higher at altitude than you appreciate. And so that's going to influence the calcium that you need. And I already saw a question pop up. Yes, that's why you sometimes feel like crap and your numbers are normal. Absolutely, absolutely true. And so that component of balancing the calcium is what I mean about having a good sort of diary about what happens when and why and how, so that you could understand, and get your levels drawn so that you can see, is it related to your blood level or is it not? And if it's not related to your blood level, is it because it's related to maybe a change of pH, which we don't measure routinely, and that's fine. You don't need to measure pH routinely. I don't recommend it because it's really an in the moment kind of thing. It's just enough to know that it's happening. So it's good enough to know that it's happening as a way of explaining, or for you to help understand, like, oh, my pH must be shifting and this must be why I'm having a problem, and to know how to react accordingly.
Gotcha. Okay. All right. Well, thank you so much. It was, gosh, just very engaging to listen to you describe what we really live every single day. So we really appreciate everything that you did this evening and your chat. And for guys out in the audience there, remember this was provided by Ascendus. So we're very grateful to Ascendus for introducing us really to Dr. Cristofides here. It was wonderful. Next week we will be together again on Thursday evening, 7 p.m. Eastern. We're going to be having Dr. Arun Matthew from Bridge Bio Calcilytics come to us and share a little bit of information from there. So thank you, everybody. Have a wonderful evening. We'll see you soon.
Thanks.